Hi everyone, and welcome to another episode of Let's Talk Risk with Dr. Naveen Agarwal. Each week, we talk about a topic related to risk management of medical devices in a very casual and informal way. This is not a webinar or lecture. Rather, our goal is to talk about key topics and challenges in a very informal way and share best practices. I'm your host, Naveen Agarwal, and I'm the principal and founder at Achieve, where my personal mission is to help you achieve success in risk management. Hi everyone, and welcome once again to our weekly Let's Talk Risk conversation on LinkedIn. Guys, I'm so excited to see you and super fired up to welcome my guest today, Dr. Olaf Hedrick. He's the Chief Medical Safety Officer at Medtronic. So we'll get to know him a little bit better today, but know that this is going to be a very, very casual conversation, very informal, very casual. And it's going to be super exciting because Dr. Hedrick actually was a practicing cardiac electrophysiologist before transitioning into industry. So we want to learn a little bit more about what it is like to now work in the medical device industry, what his perspectives are in terms of how clinicians perceive risk and how technical people perceive risk and how we can bring them all together. That'll be the focus of our conversation today. So with that, Olaf, I'm so excited to welcome you.
Naveen, thank you for that very kind welcome and hi to everyone. It's wonderful to be with you all.
Awesome. So, Olaf, I want to start by asking you just to share a couple of experiences that you had when you were transitioning into the medical device industry now, several years back, and how you really overcome some of your early challenges that you found. I'm sure there were many differences between your work as a practicing clinician and now as a medical safety officer. Can you share a little bit more about that?
Yeah, thanks, Naveen. I think, first of all, before I start, I'll say these are my kind of perspectives, my views now, having worked as a clinician in MedTech for almost a decade and a half. But yes, I mean, along the way, I've learned a lot. When I first started my first industry job, I had only ever experienced clinical practice. And, as Naveen mentioned, I'm a cardiac electrophysiologist, so think of cardiac arrhythmias and pacemakers and defibrillators and ablations. So it was in a very highly technical realm, and I recognized that I had a major limitation in that I wasn't an engineer. I was a doctor. And so when I started to think about how to influence the field and how to maybe have an impact that's beyond one patient at a time, it really seemed like a natural fit for me to look at industry as a way to practice maybe in a slightly different way. When I joined my first company, I realized very quickly a few things. First of all, I was surrounded by incredibly smart people and people who had a very different perspective on risk, on patients, on what it means to have a safe device than I did. And it was a really steep learning curve. But I think if there's one word of advice that I'd give to anybody who's considering a move like that, it's to keep a very open mind. If you are willing to learn from the ground up and learn from these really intelligent people who want to teach you, you can learn a whole new skill set and use it to complement your views. And that's some of what I've learned is actually very helpful because, this complementary view on risk, where you have both the risk management's technical experts and also end users, which in the majority of cases is clinicians and sometimes patients, gives you a really robust and holistic view. It's key to have both. Mm-hmm. You don't just get as full an appreciation of risk if you have one without the other.
Yeah, for sure. So, Olaf, looking back, can you think of one example where the difference between how a clinician perceives risk and how a technical person might think about risk stood out to you? And can you just share your experience and how maybe your team was able to bridge that gap?
Yeah, I'll mention an example, and I won't mention the device name or anything like that, but I'll use some generic terms. So in this instance, we were made aware of some adverse patient outcomes that were occurring in the routine use of this device. And it was really difficult to understand from the complaints that were coming in, which were not an avalanche of complaints. These were single complaints here and there. What was truly going on? And we were able to, as a medical group, have peer-to-peer conversations with the clinicians who were involved to really get to an understanding. And it turned out that, there was no device defect. This was not a situation where there was a problem with the device. It also wasn't a situation where the device was necessarily being used incorrectly. It was being used as intended. But nevertheless, it was having an effect on patients that we really didn't want. And we recognized that, there was a possibility that this device could be used as intended and used, on label, but nevertheless, actually, patients might be harmed as a result of its use. And so, we had to circumscribe that and say, well, how does this affect our view of risk of this device? Does it mean it's always bad? The answer is obviously no. There were risk-benefit assessments that we did to demonstrate that was not the case. But we've kept central the notion of, what's the best thing to do for the patient? And so we worked with our risk engineers and our quality engineers and external clinicians to come up with essentially a way to instruct people to use this device in a way that was actually slightly different than originally expected. We amended the use environment. We kept the device as is, and it's a device that remains in the market today and is doing amazing things for patients. And I know there's a very generic terms that I use.
No, that's fine. But I think what you're describing, Olaf, is a very common and a very tough problem to solve, because if I have looked at a lot of adverse events data, and I find like 60-70% have no association with the device. We can't figure out what's wrong. So what you're describing, I think, is pretty common. And the key point that you made that I want to highlight for everybody is that keep the patient in mind, and really peer-to-peer conversations with clinicians who are actually using it to figure out what the gaps are, right? Did I pick those 2 points correctly?
Yeah, I think those are 2 very, very central points, Naveen. I think, keeping the patient at the center of everything we do is, I think, the reason why we're all here. This is what we do. This is our space. We could be working anywhere, but we work in MedTech, and it's because we have this joint mutual desire. I think that's the other piece maybe I would say to any clinician who's coming into industry is, we don't hold the sort of sole domain of patient interest. It really is. It's distributed widely, and it's distributed amongst our technical colleagues and peers, our regulatory folks, our clinical folks, really anybody who touches these devices, including ourselves. We all want to do what's right for the patient. But sometimes our lens is a bit narrow, and sometimes we see things in a certain way that maybe others don't. And to broaden that aperture gives really everyone and ultimately the patient the best chance at a good outcome and a good device.
Yeah. So first of all, I'm so excited and thankful to hear this from you. You are echoing some of the things that Dr. Juan Dakash shared with us, and I know he's in the audience today, in the conversation that he and I had a few weeks back. So on one hand, I recognize that you are sharing this with us, and on the other hand, I also want my peers, my technical peers and quality engineers to also recognize that we also have to go more than halfway. We can't be claiming everything that is there about the device and how it's supposed to work in the real world. So that's the spirit of collaboration that I think we can bring to the party, right?
Yeah, I agree. It comes down to collaboration. It comes down to intentional communication and also ensuring that there's trust and familiarity on both sides of the equation. There is a bit of work to be done. On the engineering, the technical side, I'd say, it's very helpful if you can expose yourself to the practice of medicine, that's relevant to your device, what patients experience, what clinicians experience, what the procedure actually looks like. And as for clinicians, we need to learn some of the technical language and the concepts of risk and manufacturing and quality and so forth. There's no use in having well-meaning people who want to do the best thing for the patients, having their messages lost in translation because they either don't share some of the same experiences or they don't speak the same language.
Yeah, that's excellent. So you are emphasizing that on both sides, we have to make an effort to learn what's actually happening and learn the language. So Olaf, I want to ask you, from your enormous vantage point as a senior leader in a global organization, what are some of the key challenges that you see coming ahead? Because, my read is that our world in MedTech is changing so fast, we can't even keep up. What challenges do you see from your vantage point, especially for risk practitioners, whether they're clinicians or technical people, and some top of mind 2 or 3 challenges that we should be aware of and prepare for?
Yeah, we have a lot coming at us. I think the cadence of change is just increasing, as you mentioned. I think there's an ever increasing demand and really reliance on quantitative analytics. And I think on the one hand, that's really good because we want to be able to base our assessments on objective quantitative analyses. On the other hand, it doesn't obviate the need for us to be able to look at this as humans. We're in a humanistic environment. We deal with humans to understand what the data are showing us. And so I think the first thing I'd say is that our relationship with data not only is evolving, but needs to evolve further, where, on the one hand, we could have a very common view of data, but on the other hand, which I worry about a bit, is that, the more complicated analyses become, the more data heavy and reliant they become, that we start to silo out the way we see it. Mm-hmm. And maybe there's there's once again this sort of separation of viewpoints. I think the other is the advent of AI. Mm-hmm. For so long, AI has been discussed, and it's always seemed a bit nebulous. It always seems like a black box that never really amounts to much. But I think we're at this precipice now, for the first time, seeing AI in so many different ways, actually having really beneficial effects on patients and clinicians and devices. And yet, it does bring with it an additional need to develop more skills. And so, I guess maybe the theme that I would say is that we all of us have to develop new skill sets to really crest the challenges for the next few years here, as we become much more heavily reliant on data, devices that are putting back data coming at us about device mm-hmm. performance that are new, and how even to incorporate AI into our overall risk perspective and safety perspective. Mm-hmm. I think these are challenges, and I don't know if the answers are all clear yet. This is something that we need to collaborate on, but I see those as challenges. They're good challenges, but they're challenges.
Yeah, although I should also say that they are challenges, but there are also enormous opportunities for those who act, and those who act fast. So the key to me seems like flexibility and this never-ending thirst for knowledge and improving yourself. So from that perspective, Olaf, can you share a couple of pieces of advice for our peers, and many of them are here in the audience today, what they can do specifically to prepare for a career and maybe even take advantage of this opportunity while it's very challenging at the same time?
Yeah, I'll go back to what I said at the beginning and just lessons learned. I think, the sooner and the more vigorously, if you will, that you embrace other perspectives and other opinions and learn about other approaches, the better. And so if you're a clinician coming into the industry, really setting aside any preconceived notions, any kind of extrinsic factors that might be biasing your perspective, and truly understanding from the ground up, how this industry works and how risk is assessed, that'll stand you in really good stead. And it'll make you a partner that is recognized as being pragmatic and yet nevertheless a patient-centric partner. If you're an engineer who is maybe new in this field or even established in this field, I'll say, one of the best things you can do is to partner with a clinician that you can work with, that you maybe know quite well, and just to broaden your perspective. There is nothing better than being able to go out in the field and actually go and see a procedure that your device is being used in. Mm-hmm. I remember early on in my conversations with some peers as I was getting onboarded, one of them came up to me and said, "Hey, I've actually never been in a procedure before. I've been working on this device for a decade, but I've never actually seen it implanted." And so we actually organized for him to go to a case, and it was eye-opening because for the first time he was able to see things that he never really considered before, never thought of before. And so, if you have access to clinicians within your organization as an engineer or as a risk expert, use them. If you don't, I think forums like this, maybe even connecting with your sales and field personnel to understand if there are cases that you might be able to join or clinicians that might welcome a sort of proctoring experience. These are things I'd really recommend because, honestly, I think it's easier for clinicians to come into industry than it is for industry experts to gain exposure to clinical practice. Mm-hmm. But if you do, the world opens to you, and it's remarkable how much your view adjusts and changes, but in the right way.
Yeah. So the key point here is that we have to take the initiative. The story that you shared, this individual actually took the initiative, say, "Hey, I worked so long, I just don't know how it's used." Let's not settle within the boundaries of our job description. Let's take the step forward and take the initiative and reach out to resources in our company. So guys, this is a great time for me to start inviting you to share your thoughts. Bijan, you are already requesting to speak. The way it works, guys, is that find this button on your interface. I don't see it. To request to speak, and just raise your hand. I'll bring you here on the stage, as many as possible. Guys, we're going to have a very robust conversation. So with that, Bijan, you are already on. So go ahead and share what you have in mind.
Hi, Naveen. Can you hear me okay?
Yes, I can hear you fine. Great.
All right. Wonderful. Hi, Olaf. It's great to hear you speak. I just have had the privilege of working with Olaf in the past at Medtronic and teaching a lot of his clinicians. So it's wonderful to be hearing you. One thing we touched about is about learning, but physicians and clinicians learning about engineering and also engineers learning from clinicians. I think this really goes both ways. I know, as Olaf mentioned, when a physician enters the MedTech industry, they learn a lot about technology and engineering parts, but engineers also can benefit a lot by interacting with physicians and clinicians and learning about patients' perspective. And because they are, after all, our stakeholders, the patients and the clinicians. And that thing he touched on was about creating a sense of trust and familiarity. It goes both ways again. When engineers can connect with the clinicians, either within their companies or outside in the hospitals, and create a sense of trust and familiarity, the exchange of information flows so much more smoothly. And last thing I wanted to talk about was what Olaf talked about is, as engineers, get out in the field and see how your device is used in the field. I've had, again, the privilege of attending cardiac surgeries, brain surgeries through my work, and it just is amazing. It's eye-opening. It's really makes your work feel real, and you can appreciate how you're affecting the world.
Yeah. Well said, Bijan. And this is what I love about these conversations. You personally have so much enormous experience from an engineering side, and you have worked with people like Olaf in the past. So you have a great perspective. Thank you for sharing that with us. Phil, you are next. Please unmute your mic and share what you have in mind.
Thank you, Naveen. I absolutely agree with Olaf in a big way, and also resonate with Bijan's comments of going in and actually working with clinicians and seeing them work in their actual environment. As an example, to put it into real life terms, as some of you know, I work in augmented reality, and the headset has a kind of a tint to it, right, that makes everything a little bit darker. And going into the environment and actually putting the headset on and seeing how the headset looks in the environment was insanely useful. I was also able to grab some of that quantitative data. While I was in there, I grabbed a recording equipment to measure out the sound levels, take a recording of the noises that are happening in the environment, but also able to record the light levels. And it varies in the room depending on where you're standing in the room. Generally, as most people, most medical professionals know, the outside of the room or the outer area of the room tends to be a little bit darker, and the operating area tends to be quite a bit brighter. And it was interesting to see how that came across in augmented reality.
That's just really awesome, Phil. But I do have a follow-up question to that. How did you decide to actually go do this work? Did it happen almost organically? Was there a question you were discussing? I'm very curious as an engineer, how did you take that initiative to go do this?
Yeah, it was, not getting into too many details, we're developing a new system, and the new system had a new user group and a new user environment. So that's what kind of prompted me to go out and gather this information.
Wonderful. Thank you so much. Juan, I'm so excited to... go ahead, Olaf. Did you want to add to that a little bit?
Oh, sorry. No. Well, first of all, I just wanted to comment on something that Phil said, and Bijan, it's great to hear your perspective. I've also had the privilege of being able to learn from Bijan. I think what you said is true. It's definitely a two-way street of learning. But Phil, I appreciate what you said. I think when you were talking about that example, one other example came to mind. So I'm from an operating room kind of environment, electrophysiology, and when you're in a procedure like that, there are so many inputs. Clinicians actually struggle with integration of these multiple inputs. There's auditory stimuli, there's visual stimuli, there's tactile things going on. And, if one is focused on developing one particular part of that whole ecosystem of devices, that system of systems, you may be very focused on is this just is this enough tactile stimulus for the clinician to be aware? If you put yourself in that actual use environment, you go to the gemba, so to speak, and you as an engineer understand what the totality looks like, not just for the clinician but for the patient too. You're bound to make very, very well educated decisions and choices. And so I'd say that's great. And then I'd say for clinicians too, I mean, availing yourselves of opportunities to inform things like human factors and design, if there's an opportunity to do that, I think can sometimes stand you in good stead.
Wonderful. Thank you so much for sharing that. Juan, I'm so excited to welcome you here. Great to see you. Please unmute your mic and share what you have in mind.
Hi, Naveen. Thank you. Well, the pleasure is mine, and Dr. Hedrick and Bijan. I know we have been in the same room together in the meeting that Bijan helped organize, and I'm just so happy to hear that, when an MD transitions to the medical device world, they feel kind of the same thing, and that you're not alone. And obviously, always keep that growth mindset and learning towards cross-functional collaboration, because as Dr. Hedrick was saying, that's the key. Trying to develop that same language, but in order to get there, everybody has to help each other out, ask questions, and don't judge. When you're coming from a medical realm, you are the subject matter expert of what you're doing, and you're coming into a company that needs your expertise, but not to be the sole proprietor of the direction where to go, but to be a team player in bringing that information. So that is key, and getting to the same language is very, very important. And the way I see it in an analogy with risk management, Bijan, is this is an example that I used to give because I'm an orthopedic surgeon. I used to do joint reconstruction. And when I sat down with engineers from a hip, for example, a specific team was looking at the femoral component and the head. And then a separate team was doing the risk management for the acetabular component. And then my first question was, well, who is doing the risk management of both of these combined as a system? And that was, crickets in the room. So in that same analogy and line of thought, you need to be looking at risk management conversations with your engineers as a system, your perspective from an MD perspective and the engineer's perspective. And then, Phil, I can't even start by saying how important human factors and usability is in the medical device world. That is clear and important. But maybe a follow-up question that I have for Olaf, and I know, Bijan, we've talked about this. There is a growing population of students in med school that are looking into transitioning to industry directly after med school. But we're not teaching, or at least not that I'm aware of, in our curriculum, risk management and conversations with engineers and all of this. So I would love to hear your perspective on how we can start incorporating that into, even as an elective, right, in our curriculums for med school.
Fantastic question, Bijan. Go ahead and please share what you have. And I will also invite Olaf to share his thoughts.
I have always been a proponent of including risk management in both biomedical engineering and medical schools. And I have been working relentlessly to try to persuade universities to do that. In fact, I was just talking to the head of biomedical engineering school in University of Melbourne, Australia, about adding this. And he was interested in, I'm going to be going there to talk to him actually in about 3 weeks. There are some universities that do offer this, but engineering schools, I'm not aware of any medical schools that have opened up to adding at least an elective in risk management for medical students. But I would love to find somebody that's interested and talk to them and see what we can do for them.
Yeah. Go ahead, Olaf, please.
Yeah, well, first of all, I'll say, Juan, it's a pleasure to hear you speak. I really enjoyed your podcast, and in fact, I wasn't able to join live, but I caught up afterwards, and a few of my colleagues even commented and said, "Well, that was just fantastic." So, I think the more voices that can sort of cross-pollinate ideas, I think the better. I think what Bijan said is true. That there is generally no formal medical education or training on principles of risk management. In medical school or in postgraduate medical education, which seems very odd. And it kind of gets to this concept of this sometimes divergent way in which clinicians and traditional technical risk engineers view risk. But I agree. I think there's a lot of scope for it. I think there's a thoughtful conversation to be had about this. when you start to, at least from my vantage point, sometimes when I have discussions with clinicians outside of the company, people who are in practice, this comes up sometimes, especially in academic settings, where they say, I wish I had a better handle on the medical device industry. That's usually how the conversation starts. But really, what they're asking you is, how do I view risk every single time that there is a communication about a device, or there's some sort of new guidance that comes out? Am I supposed to see this in isolation, or is there a theme here? And how do you determine these risk levels? So there's really, I think, there's an appetite for it, I believe. I think it's a bit of a groundswell. So, Bijan, to your point, maybe there's some opportunity here.
Yeah, great.
If those of you in medical schools that hear of anyone who's interested in at least exploring the possibility, I would love to talk to them.
Yeah, absolutely great. Thank you so much. Ed, you have joined us, and I know you have been involved in this field for so many years. I would love to hear your thoughts on this conversation. Please unmute your mic and share what you have in mind.
This is a great conversation, and I'll start. I've got two major points here. The first one is communication. As an example, and I've talked about this before, I think, there's 17 definitions of the word risk in the Cambridge English Dictionary. So which risk are we talking about? That's the first thing, because often what happens is we're talking over each other because we're using different terminology for the same word. So we got to come to a common understanding. I learned this in the standards groups as we tried to settle on some words. For instance, in 14971, we talk about the probability of occurrence of harm. Well, we had to use the word probability because we couldn't use the one we wanted to use, which was likelihood, because it could be either qualitative or quantitative. And usually, when you're starting out with a new product, you're not going to have a sufficient statistical validity of the data to do quantitative analysis. You're going to have to wait until you have sufficient data. So there's that pathway. The other is someone brought up the word systems in here. And in combination products, which is another interesting field where we have either a drug and a device, or a biologic and a device, or a biologic and a drug working together, one of the things that we've found there is that isolation, those silos where the drug people do their risk analysis and the device people do theirs, but what the user sees is not the drug or the device, but the system working together. So we have to learn the systems approach for risk management so that we can take into account all the things that affect the system. That means human factors, biocompatibility, AI, all these elements come together to affect the risk of our product. And we have to develop a systems approach so we can consider all of those things together as we develop our risk approach.
Fantastic. Thank you, Ed, for sharing those thoughts. Guys, with that, we are running out of time. But, I never say no to anybody who raises their hand, even at the last moment. So, Abhinav, that you are on. Please be brief. Share what you have in mind.
Yeah, no, I think I thank you so much for having me on the call. And it's a great talk, a lot of good conversation. I had a lot of things in my mind, but I just wanted to bring one point. I think we spoke about risk of different factors. We also spoke about combination product and, cross product and systems, or, even individual components of that system. One thing I wanted to bring up light about cybersecurity and how that actually feeds into, different aspect of risk within systems and, softwares specifically. And considering that in mind and trying to relate to the end user, I think would need a lot of combination of conversations, communication, and learning on both end, because from a software perspective, purely technical speaking, you would have some kind of understanding that how this risk would feed back into, your risk and hazard.
Yeah.
But then from the user perspective, like Dr. Olaf or, any other doctor, you would get a perspective and insight what actually that would entail into.
Yeah.
So I think that is also one of the area which I think
absolutely
would need a little bit more insight.
Yeah, I love it.
Yep.
Love it, Abhinav, for bringing this point. We have started talking about cybersecurity, guys. We just had an LTR session with Nidhi Kani just a couple of weeks ago. We're going to touch upon it more. And what I'm hearing from you, Abhinav, that is there's an opportunity here to talk about the interface between the clinician and the software engineering people in the user environment. So we'll take that on. Guys, unfortunately, we have run out of time. So I want to give Olaf a couple of moments to think about some key takeaway points. But in the meantime, here are a couple of announcements for you. First, next week, I'm so excited to have this conversation with Michelle Wush, who is in the audience today, about the application of AI in the regulatory space. Guys, you don't want to miss that because she has a couple of very interesting use cases that you want to learn about. So keep an eye on the announcement that's going to go out on LinkedIn today and sign up. Second, mark this on your calendar. We meet every Friday at 11 Eastern. Even if you are busy otherwise, you can show up or not show up and find a recording later on the Let's Talk Risk website. But if it's on your calendar, it's going to happen and maybe you can join us. Finally, I want to do a call out here. I know that without exception, and I believe it in my heart, all of you, without exception, have something very interesting and unique to share with us. Please don't hold back. Share your knowledge and wisdom with the world. Come on board and contact me. Reach out to me if you want to be a guest speaker. It requires no preparation, okay? You don't have to make any slides. You don't have to give a big presentation. Just be open to having a conversation. With that, Olaf, I would love to have you share just 2 or 3 key takeaway points from our conversation today.
Naveen, thank you. And thanks to everyone. This was really a lot of fun. I appreciate it. I'd say my key points are, reach out to bridge the gap. It's through collaboration, it's through communication without fear or judgment, assuming positive intent is the first thing. And the second thing is always seek the best voice to represent the patient's view. I mean, this is really why we're here. Sometimes even if it's the patient directly, we didn't even get to touch on patient perspective of risk today, but I think if we center things on the patient and we keep an open mind, collaborate openly, I think we can get far.
Wonderful. Thank you so much, guys. I want to ask you in the audience, how are you feeling about this conversation? Share your reaction using emojis. I want to hear from you. By the way, you can always reach out to me one-on-one through LinkedIn. Share your feedback, what you like, what you don't like, what you would like to see happen in the future. This conversation is for all of us. So I want you to be a part of it and help us achieve this excellence in risk management that we strive for together. So thanks once again, guys, for joining. I look forward to seeing you next week. Thank you, Olaf, Phil, Bijan, Ed, Abhinav Dutt, and I know Juan had to leave, but thanks for all your participation and sharing your insights. Take care, guys, and we'll see you again next week. Bye-bye.